Even, however, these heavy plates can have problems. Here's a situation where this was a guy in his 70s, actually. This was a pathologic fracture of his mandible from disease. And even though this is a heavy plate, he managed to break it in a relatively short period of time. One of the things that can be associated with hardware failure like this is if there's too much plate bending when you're trying to fit the plate. So this is a situation where you know what happens if you take a paper clip and bend it repeatedly, it's going to break eventually. If you're doing that, especially for novices that are trying to bend these plates, because the plates all come straight, you have to contour them to the mandible. If you contour it too much, do too many bends in the thing, you weaken the metal and they can fracture. So we don't like to see that. You want to do the minimum number of bends to hold things in position. Nowadays, you can get custom plates, but they can take a week or 2 weeks in some cases to be designed with virtual surgical planning, and that is rarely done nowadays. External pin fixation. I'll show a couple of these cases. This is a gentleman who had a mandible fracture, and if they are infected in particular, a lot of times it's difficult to get plates on an infected site, and you certainly can't do a bone graft in an infected site like this if you got pus pouring out. So in some of these cases, we want to treat the infection first, stabilize the fracture and hold it in proper position. Then we can go in and do a bone graft later after it heals, and this will still hold the fracture stable so that the graft will take and the fracture will heal. This uses pins that penetrate through the skin into the bone, and this is actually an endotracheal tube that is placed over the pins, and we inject bone cement, which is essentially glorified orthodontic acrylic, into this. As it polymerizes, provides rigidity across the fracture line, and the patient can wear this while the fractures heal. Downside of this is this becomes tempting for people to grab onto. Many of these fractures occur in bar fights, and you gotta believe this guy goes back and gets somebody upset, they're gonna grab onto this thing and pound him even harder. So that's what it looks like. You see the pins coming through the skin, and they can stay in place. You need to keep an eye on these. You don't want to get infections around the pins as they come through the skin. You can also do this with metal frames externally, or there's other ways. This doesn't illustrate an endotracheal tube, but there's actually trays that are manufactured to do this so that you can make acrylic bars externally and then take the metal hardware off and leave the plastic on, like so. This also illustrates pretty well ecchymosis around fracture sites. Okay, so you can see that there's bruising. The bruising will indicate where the fractures are. Next, we're going to go into the midface. Now, the midface includes the maxilla, zygomatic bone, zygomatic arch, which is partially zygomatic bone and partially temporal bone, the orbit, which has lots of bones associated with it, and that's something you guys probably needed to know for your Part 1 dental boards, the nose, and the paranasal sinuses. Paranasal sinuses are all paired structures, so there's 2 of each paranasal sinus, or more in the case of ethmoid sinuses, where there's multiple small sinus cavities in the area of the nasoethmoid region. So common fracture patterns we see are the Lefort series, Lefort 1, 2, and 3. We'll spend some time talking about those in a minute. Tripod, also called zygomatical maxillary complex or trimalar fractures. Orbital blowout fractures, that's orbital floor, although orbital walls can also be fractured. Nasal bone fractures, very common. Nose is prominent, easily injured, and we see quite a number of these. Naso-orbital ethmoid, not as many now with airbags, but used to be more common when drivers of cars in particular that hit something would be pushed forward into the steering wheel, and they would tend to hit right at the bridge of their nose and fracture this region, and then sinuses. So sinuses we're concerned about are maxillary ethmoids, and I say there's multiple ethmoid sinuses, sphenoid, which is in the skull base, and frontal sinuses. So when we examine these patients, you used to say ABCs, airway, breathing, circulation. Well, it's been modified to breathing first, all right, then control of the airway, and then circulation, okay? You want to control hemorrhage from these things. Mid-face fractures can bleed a lot, and they can compromise the airway fairly quickly. So they're injuries that we want to keep a close eye on. And if there's significant bleeding or hemorrhage, this can be an emergency that needs to be fixed immediately. You want to palpate the anatomic structures, see what you can feel that's out of the ordinary. That will help to guide your imaging. And imaging for these fractures is almost always CT scans. Come up with a treatment plan. Not all of these need to be treated. Many do, but probably no more than half of mid-face fractures actually need treatment. And then there's urgent versus emergent intervention. So if you have airway compromise, if you have uncontrolled bleeding, if you have brain coming through frontal sinuses and things like that, that would make it emergent. Otherwise, we treat them once the patient is stabilized. Many patients with these types of injuries have other serious injuries as well, either internal injuries or orthopedic injuries that take precedence over the facial stuff. In the absence of airway problems or uncontrolled bleeding, facial fractures can wait 1 to 2 weeks in many cases before they have to be managed. So just like with the mandible, there's all kinds of imaging that can be done. Panoramic is common. Plain films in some smaller hospitals, but even the smaller hospitals now pretty much have CT scans. Polythermography is available in some places still, but is not a routine type of imaging, and you really don't need to know much about that. Computer tomography is the standard, and one of the things about computer tomography is we can see the images in all 3 dimensions. So we can see axial, coronal, and sagittal. It doesn't say sagittal here. That's probably the least helpful, but the images are obtained in an axial plane, but with the software nowadays associated with CT scanners, you can get pretty good images in a coronal and sagittal plane. And as I mentioned previously, you can get good 3-dimensional images that can really give you a handle on where bones are, what needs to be done, what you can reach and what you can't reach surgically, and come up with a more thorough treatment plan than you could in the olden days when only plain films were available. In some special cases, we may want angiography, and that includes penetrating wounds, either knife wounds, other sharp objects, or bullet wounds, because in many cases, these missiles or things that have penetrated the neck may have damaged major vascular structures, and if we can't control bleeding, the patient will not do well. So plain films, on this image you'll see on the patient's left, the right side of the image, that's a zygomatic arch fracture. So that shows up pretty clearly, and you can compare it to the other side. Nice images, but again, it's even nicer if you have it on CT scan. So CTs are, as you can see here, pretty helpful in imaging these things. This is a patient with frontal sinus injury, and you can see that the left side of his forehead is pretty caved in. So a couple issues when you're thinking about these types of fractures. Sinus fractures, one of the concerns is, will the sinus drain afterwards? Because if they don't, you get mucus that backs up into the sinuses and form what is an actual real mucocele. And mucoceles in the sinuses are destructive lesions. So they will actually erode bone, they cause pain, and they can cause, in an area like the frontal sinus, you can actually get some brain symptoms from these. CTs provide the best images, no question about it, and that's why we get them most of the time. Here's a CT image in the coronal plane, and this is a soft tissue image, so you see the bone is kind of not very detailed, but you can see more soft tissue. This patient's left sinus, that's the side where the L is, you can see has density in the sinus itself, that's blood. And what you don't see here is the floor to the sinus, and that's because it's fractured and displaced. On the opposite side, you can see a sinus floor, but on the patient's left side, that's the inferior rectus muscle that's down in the sinus, that little white thing near the bottom. And those are fractures that will need to be repaired because they will restrict eye movement. Clearly, the three-dimensional CT scans, and this is a film that's only 4 or 5 years old, you can see the detail that we couldn't have imagined 25 years ago. Right? So this patient has a frontal sinus fracture. If you look at the forehead, that's all crunched. The patient's left orbit is also in multiple segments. The right frontozygomatic area is fractured. The maxilla is fractured. And you can see the sinuses. You can look into the sinuses. You shouldn't be able to look into the sinuses from this image. So all of these are comminuted fractures, multiple segments. But it gives us a pretty good idea in advance of what we're going to get into when we try and repair these. So with internal fixation, you may see in some of these notes on these patients, ORIF. That means open reduction internal fixation. We use plates and screws. There's all kinds of different sets. You can see all different shapes of bone plates here. This is a segment for the midface, so it's got smaller plates. Comes with appropriately sized drills that are color-coded to the plates typically. So, you have a good sense of what you're going to need to do, where the fractures are, the type of plates you're going to need. These plates in the midface, the smaller ones, you can bend with your fingers. They have bending instrumentation to do this. But again, you don't want to bend them repeatedly because they can still break. All right, let's get into the fractures themselves. The Fort 1 fracture, fairly common. It includes the tooth-bearing area and the bone surrounding the teeth. All right, it doesn't have to be a single piece like you see here. You can have the maxilla broken into 2 or 3 pieces, but it's separated from the areas above. So it looks kind of like a denture. Here's a 3D CT of one, and you see the red arrows illustrate where the fracture lines are. This patient also has a midline fracture. You see there's space between the teeth, and that is because there's a fracture that goes right down the palate as well. So they're not